trying to teach you how to be a CRNA. I've got to teach you how to be an RN before I can teach you to be a CRNA. Okay? I'm just giving you, because you're not going to administer these medications. Okay? The CRNA is going to be the one that is administered. I'm just giving you an overview of what to expect when your patient's on anesthesia, or what is anesthesia. So, anesthesia is a negative sensation, and it actually blocks the impulses. So we have a goal of what anesthesia, what we want to happen when patients get anesthesia. We want them to have no reflexes. Now, when I say no or suppress their reflexes, what is going to be the number one reflex that's going to worry me if it's suppressed? My gag reflex. Okay? That's sort of scary as a nurse when I think, oh my gosh, they don't have a gag reflex. That's sort of scary. So you got to remember that what this medication is doing to this patient is suppressing his reflexes. So he is not going to be able to do what? Maintain his airway. Okay? Not going to be able to maintain his airway by himself because the gag reflex is suppressed. Okay? That's scary. It's going to promote relaxation. Muscle relaxation. I mean to where they're almost paralyzed. So they have no ability to move any part of their body by themselves. Okay, so now we've got to potentially, or suppress reflexes. We've got complete muscle relaxation, and they're unconscious. Okay, so that's, or their level of consciousness is going to be altered depending on the type of anesthesia they have. Okay, so those are pretty serious things right there, aren't they? So I gotta make sure that I understand that when my patient has anesthesia, that these things are going to happen. All right, so whose responsibility is it to select the type of anesthesia? My nurse anesthetist. Should I turn this off?
Yes.
Yeah. Why are y'all just now telling me?
There, that's better.
Is that better? Y'all tell me when you can't see something. I can't even see the red. Here I am trying to be pretty up there. Y'all can't see it. All right, so the nurse anesthetist is going to make the decision on what anesthesia or how the anesthesia is going to be given. It's based on the type and length of the surgery. So if I have a patient who's going to have a 6-hour surgery, you can bet that that's going to be some high-dose anesthesia, right? Because I got to keep that patient under for a long period of time. If it's shorter, then I don't need as much. That's not your call, that's the CRNA call, but that's just how she makes the decision on what she chooses. The area of the body is another thing that she looks at, because we've got to remember in the abdominal area, those lungs are right there. And I really would prefer that my patient has good lung function when they're under anesthesia. So that's how they decide the area. Is it an emergency or not? If it's an emergency, we're going to push it and go. Options for pain, post-op pain management. Some patients will get general anesthesia, but they also will get an epidural. Or they'll also get where we can connect their PCA up to it. So with an epidural, they may have the epidural, which is anesthesia, and general. And the reason why is, let's say, like with my hysterectomy, I had an epidural because I want to be numb all the way down here. I don't want to feel any of this stuff. So I can keep the patient's pain under control post-operatively. So that's why they would have done two different things. How long has it been since they had anything by mouth? We want them to go 6 to 8 hours, but if it's an emergency situation, I may have to give them more anesthesia relaxation anesthesia if they've had anything, because I'm going to have to put an NG tube down and drain their stomach. Okay, because they've had something to eat. That's the way we get the food out, is by putting that NG tube down. So I don't want my patient to have to go through putting an NG tube down, do we, Lauren? If we don't have to. That's why I want to make sure that they hadn't had anything to eat 6 to 8 hours before, because there's a risk of aspiration. And the positions that are needed. These are all different things that the nurse anesthetist, not you, the nurse anesthetist has to look at as she makes the decision on how much medication and what type of medication that she's going to give her patient. That is in the pre-op area, where they look and say, okay, how did you tolerate anesthesia?
So it's not like something that plays into their decision, or they just already have the information.
She already has the information, i.e., I think I told a story the other day about I vomit. Every time I would put to sleep, I vomit. So that may be an addition to the anesthesia. Something for nausea, like Epidural or something like that. But it's not going to affect my anesthesia. They're still going to put me down, but they're going to add something like Zofran or Epidural or something like that, because they know I'm going to throw up. And of course, they've got to look at safety issues, because that airway is going to have to be maintained. And I know that I keep saying that to you guys, but when you actually get in the OR and you see someone whose airway is not maintained, it's scary. And you know that that nurse anesthetist is doing everything that she can do to make sure that that airway is good and maintained. All right, so let's talk about general. There's different types of anesthesia. One of them is general. And when I say general anesthesia, this patient is totally unconscious. And they have lost all sensation. But the biggest thing, and we just talked about this, is our protective. Do you realize that a gag reflex is a protective reflex? We have to remember, when patients are under general anesthesia, their protective reflexes are lost. They have no ability to cough or gag. And that's scary, because every day we have the ability, if we get a feather in our throat, we can cough and get it out, right? Or if we get food, not going down the wrong way, we can cough. These patients can't do that. All of their protective reflexes are totally lost. And I need you to realize that when a patient goes under general anesthesia. We look at the different. General anesthesia is more of a combination of drugs, all doing their thing for us to maintain 4 different areas. Does that make sense? So we're given not just one drug, we're given a combination of drugs. We're going to give a drug that's going to work in the centers of the brain that affect amnesia. I don't want my patient to remember anything that they went through when they were in the OR. I don't want them to remember us setting them on their head. I don't want them to remember that we had huge retractors in their abdomen and pulling it all the way open, so all their organs are hanging out. I don't want them to remember that. Okay? So general anesthesia is going to give me a medication that's going to help with amnesia. It's also going to help with pain control. I'm going to give a medication, because I don't know about you, but I just think about my abdomen being all opened up with retractors. That hurts to me, just thinking about it. And sometimes when I look at the patients, especially those that have total hip replacements or total knee replacements, and they're in there and they got a hammer and they're going bam, bam, bam on that patient, and they're going drilling all that stuff. I'm telling you, it happens. I don't want my patient to hurt. So all these things, don't y'all like the animation?
Wait till you hear yourself on YouTube.
What I really feel sorry for is the people that are that may listen that have no idea who I am.
Like laughing at me. If they're in a band, you sit down, listen to the lecture, and you're like laughing.
If I had to listen to me more than one time,
It's Miss Yost, and you'll die.
And you'll die.
in my spare time, maybe that's what I'll do. Listen to YouTube. So, do you see? I don't want them hurting. So I've got to give them some medicine that's going to help them not hurt. Hypnosis, artificial sleep. I want them to go to sleep. I don't want them to do any. I want them to just lay there. They don't have to do anything for themselves. We got this. Okay? And relaxation, I don't want them to be tensed up because when they're in pain and something's happened, think about what you do when your patient goes, you go give your patient a shot. What do? Now, if I'm all tensed in the OR, is the surgeon going to be able to do what they need to do? So you can see that it is a combination of things that I want to happen when they're under general anesthesia. Now, this is something that State Board of Nursing is not going to want you to know this. And I know I should say, y'all should know this. But what I want you to realize is that under general anesthesia, as a nurse right now, if you go to get your CRNA, you're going to learn so much more about this. But what you, as a beginning practitioner of being RN, you understand that the patient goes through different stages of anesthesia. And one of the biggest things that you can see are happening is that how you, as a nursing student and how, as a nurse, need to respond because you know that it's going to take them a couple minutes to get through these different stages. For instance, the induction part. Obviously, that's going to start at the very beginning when the patient begins to start losing consciousness. They begin to be very drowsy. They're not having anything, they're not feeling any pain. They're just sort of getting ready to drift off into a wonderful dreamland. But as they go through this induction, it is very important that you are quiet. Because remember, the last thing that we hear, or the last thing that goes is our hearing. So I don't want a lot of cutting up, laughing, because it may interfere with the way the patient is going to get the medication. So at that point, when they start, and the CRNA may look at you and say, shh, and they've told me to shh before. When I had my student in there and I was trying to tell them, here's your circulating nerves, here's this, and the CRNA started with her induction of anesthesia, and I didn't realize it. And she didn't hesitate to tell me to be quiet. Okay? The patient needs to be, they don't need to hear a bunch of jibber jabber. They don't need to hear the music rumbling in there. They don't, even though it'll come on after they go to sleep, believe me. I think Carrie's room, you could hear their music all over the OR. Yeah, I mean, boom, 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 you know. I'm like, we can't have that for the induction. Everything has to be quiet. People need to stay out of coming in and out of the room, and we just need to have our patient to be very, very relaxed. No, it doesn't make them, because that has nothing to do with you still have relaxed. Yeah, we want them, because I want them to be relaxed so I can get the tube need to be going down them. And I also want to see, or the CRNA also wants to see, how are they reacting to this medicine? Am I having to give them a bunch here? No. I want the minimum amount to get the process going, but I want them to be able to be relaxed and let the medication take over. All right, so at this point, the patient is going to be, they're going to start getting ready to intubate the patient. You know what I mean by intubation? They're putting a tube in their airway to maintain their airway, because we know with general anesthesia, all protective reflexes are lost. So I'm going to have to maintain that patient's airway at this point. So as they'll take a little bit of the gases, and we'll talk about the gases in a minute, and then they'll put the actual tube down. As you see, when the patient begins to lose their consciousness and they become real relaxed and they start losing their reflexes, the patient may have an irregular breathing pattern. They may see that happening. A lot of times they may have involuntary movement of their extremities, because the body's trying to take the medicine and let it work. But sometimes you may see an arm go fly up or a leg go fly up or something. So remember, that's why we got to make sure that they're safely positioned before I start getting this medicine. I got to make sure they're padded. I got to make sure that that safety belt's on. I got to make sure that when I move that bed, they are not going to slide out of it. Okay? So you've got to be good and relaxed. Another thing that may happen, I don't know why I keep trying to lose my voice. It's the sound effects. No, it's not. What happens is, you remember that we are going down into the trachea when they put the tube down, and the larynx is right there. And so what may happen is they may stimulate the larynx and it begin to spasm. And if it starts doing that, then the patient may not be able to be intubated, and they may end up having a trach as opposed to a ET tube put down. And I don't want to have that happen. So the CRNA is going to be watching for laryngospasms with the larynx starting to spasm. So that is a side effect. They may also vomit, but the good thing is that the CRNA does have an NG tube right there, and if they begin to start vomiting, they'll just slide an NG tube down for the patient. Okay, so those are just things that you may see during the induction phase. Or am I in the maintenance phase now? I'm in the maintenance phase. All right, operative. At this point, this is when the patient cannot hear you anymore. They are completely gone. Well, let me just say under. How about that? They're completely under. No reflexes there. No pain. They're not remembering anything, and they're completely relaxed at this point. Right. It's called a biz. Right. Drug. Actually, and what that is called a biz. I think that's the biz. Yeah. What it does is it gives us an idea, or gives them an idea of where the patient is as they're going through these stages, and to see how receptive they are to the medication. Are they completely relaxed? Are all of their reflexes completely lost? So that is a tool that CRNAs use to assist them in where is the patient in these stages. Okay, because they have to be ready, they have to be receptive to the medication, because there's sometimes you can't give them medication until they show you all the signs of going through this stage. But as an RN, you shouldn't have to worry about that. That's a CRNA, and that's just using their tools to know, is this patient going to sleep? Are they doing what they need to be doing? that I can get everything ready for this surgery. Okay? So this is the stage that I want them to be in. When they're in the OR, I want them to be right here, because I can do anything to them, the surgeon can do anything to them, and they are going to have the adequate sleep that they need. They're not going to remember anything, and they're good to go. The next stage is one that I worry about, the danger stage. In other words, I think of the CRNA that she is trying to not get to this stage. I want to go all the way to the operative stage, but I don't want to get into the danger stage. Because when I get into this, what's happening is that my patient can go into cardiac arrest. Now, even though your patient is on a ventilator, they still can arrest. You know that, right? You know that they can still have cardiac arrest. The one good thing is that they're on a ventilator, I got their airway going, right? And I got something going on with their lungs for them. But I got to make sure that they don't get to this. And what you'll see is the patient will arrest, and then, even with the ventilator on, they will start having signs of apnea and start having respiratory depression. This is never good. So, I really don't want you to, I want you to realize that there are stages that you go through with anesthesia, but I don't want you to sit there and memorize, well, this was what happened in this stage, and this is what, that is not your scope of practice, okay? I just want you to be aware that these happen. All right, so my voice is driving me. All right, so let's look at the different meds that the patient, that they will be getting under anesthesia. Inhalation. You know what it means to inhale something. So this is one of the medications that they give when they get ready to go to sleep. You know what happens with the respiratory tract. As you bring something in, if you breathe it in, it goes to the alveoli, exchanges, and comes back out. So we have the patient to inhale the gas. This is what they use for pediatric patients a lot, to get them to start going to sleep. And we talked about this yesterday, about our pediatric patient. We have them breathe that gas, and it puts them a little bit under, and then we can start the IV and do all the invasive stuff that we need to. So the different types of inhalation agents are nitrous oxide. That is the most common one, and that is really the major one that boards questioned you about, is the nitrous oxide. It's very, very common. Very, very clear, has no color, has no odor, but it's like administering 10 milligrams of morphine. Now, I don't know if you know your dosage range for morphine yet, but that's a pretty doggone high dose of morphine that you give your patient. So they're like, they're going under. These four medications are just examples of the medications that they can give inhalation-wise. I don't want you to focus on anything except the nitrous oxide when it comes to inhalation. All right, then they also give IV medications. Obviously, straight into the IV, and we know that metabolism has to work. So the IV medications, they go directly to the CNS, and it causes, that is the medication that causes our patient to lose consciousness. It is pentothal. Have you ever heard of Michael Jackson drug? That's how every one of the nurse anesthetists down there say, well, this is Michael Jackson drug, because this is what happened with him. Pentothal. This man works so fast. This is the drug I was telling you about that the CRNAs just get. They have the whole syringe, looks like milk, the whole syringe, and they just give a little bit, just to see how the patient, because this medication can cause respiratory depression. And this medication can make patients stop breathing. So I don't want to give them a lot of this if I don't have to. But I need them to go to sleep. I need them to go down. The bad thing about this is there's no antagonist, yes, that will reverse the effects. There's some medications we can give them, i.e., if I give my patient too much morphine, what can I give him to reverse it? Narcan, right? I can give Narcan. This drug, I don't have it, so if they take it, it's got to go through the processes of medications, i.e., absorption, metabolism, excretion, all that good stuff. It's got to go through that, or it's not. I mean, and that's a bad thing.
Do you know what the typical time frame is
That typical time
for
frame
it to work out of their system?
No, I do not. I do not. But that's something that we can ask the CRNA.
I know when I was in my very first clinical, I got to go down at Rowan for my patient who was doing the hip, and that's one of the things that she was saying is they push such small amounts because then in post-op, everybody's upset with the CRNA if they've given too much medication and they don't wake up fast enough.
Right.
It slows the process for everybody behind them.
Yeah.
And she said everybody was individual, and it's not just based on, it is a lot based on weight, but not just necessarily if they
We're
have
looking
other
at every
disease
individual
processes.
person. So that's why they just push just a little bit at a time. Wonderful, 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 wonderful. All right. Another one is this Kinelar. They use that, but not a lot. I always go to Amy every year and say, okay, update me on all the meds. So I've got the updated of ones that she gives, but if she gives the Kinedol, that is the majority of the ones we're going to see. But this does the same thing. And it has a rapid onset. And there again, I don't want you to get so keyed up on all these drugs. I do want you to realize that this Ditrovan, it is given if we want somebody to go under quick and wake up quick. So this may be one that a nurse anesthetist decides to give if she knows that the patient's only going to be under 30 to 45 minutes. So this is going to be a very short procedure. She may not want to use the pentothal because that acts a long time. Or longer time. Huh? Yes, this is what we give and we do endoscopies or colonoscopies. So something that's we gotta get in there, look real quick, and make sure that they are not gonna be under a long time. They're also gonna give pain medication. So remember, general anesthesia, there's a combination. So we're giving propanol, and we're also going to give them something for pain. Now, this is not like the Tylenol we were talking about. Okay, this is not the Tylenol yet, because the Tylenol is going to be given at the end of when they get ready to wake up. So this is when we're putting them all to sleep. I'm not going to give them Tylenol. They're going to need something a lot stronger, like morphine or Demerol. One of the biggest things that they're using now is fentanyl. Fentanyl use is working so good for patients for pain control. It's also, we can use it post-operatively, that patients are really, really responding very well. It doesn't seem to knock them out as much. I mean, of course we want them knocked out here, but post-operatively, they don't seem to have the side effects that they would have with Demerol and morphine. So they seem to come out of that really, really good. Of course, we want to give the anesthesia part of this, the pain medicine. because that's going to help relax the jaw as well. Because I want my patient to be totally relaxed so I can get that ET tube down them and get them intubated as quickly as possible. These are all pain medications that are going to help work with to decrease the pain. But one of the biggest side effects that you see with this part of the combination is muscle twitching. So you may actually see the patient while the anesthesiologist or nurse anesthetist is administering this medication, they start twitching like that. That's why the CRNA has that tool of the biz to use, because we're seeing if their reflexes are totally paralyzed, and if they're twitching, they're not ready for the next medication. Okay? So remember, this is a combination. And I got to make sure that each one of these, or the CRNA makes sure each one of these medications are given in a timely manner to receive all the things that need to happen under general anesthesia. And this is what I keep going and saying, that we've got to remember that general anesthesia is like a balanced anesthesia. I've got to make sure that everything is balanced, that all of those things that we talked about, those 4 things that are going to happen, is happening with this. There are hypnosis, amnesia, pain relief, and all reflexes are gone. Okay, so that is the goal of having a balanced anesthesia. And I just give you an example of the different meds that are most commonly used. We know that the pentothal that's when they're going to go to sleep. I'm going to give them the nitrous oxide for amnesia purposes. I'm going to give them the morphine for pain control. And I want to make sure that that all their muscles are relaxed. So do you know what I'm saying when I'm saying there's a balance or there's a combination for general anesthesia? It's not one drug that puts them and does one thing. So remember, you're not going to be administering these, but aren't you going to be taking care of the patient after they've had these drugs? So they have had 4 different drugs, and you've got to know what the side effects are, because they're going to know. You've got to be looking, because you're going to get them post-operatively. Okay? All right, so when we look at anesthesia, there's a lot of complications. But one of the biggest complications that we're going to see, and luckily, we don't see it a lot. Praise Jesus, we don't see it a lot. But it happens. It's called malignant hyperthermia. And when you hear that hyperthermia, what do you think? Oh, they're going to run a high temp. The bad thing is when they run that high temp, it's about too late. And that's the stinky thing about this drug. Every nurse anesthetist will talk to you. You ask them about malignant hyperthermia. They don't want to see it happen. This is a life-threatening complication of anesthesia. Very, very scary. One of the things that usually, or the people that it affects most, is our young children and younger adults, like me, young adults. And the bad thing is this happens so quickly that you gotta move. You gotta move on. So this is the nurse anesthetist's responsibility. And what's gonna happen is you have calcium. I was like, which electrolyte am I trying to say? The calcium immediately elevates. You see, the muscles from the being put to sleep, because we've got complete muscle relaxation, right? So as our muscles are relaxed, the calcium starts shooting out of the muscle and shoots to the bloodstream. And it becomes extremely, extremely high. And with calcium being elevated, potassium's going to be elevated as well. So you can see where we're going to have the cardiac issues we're getting ready to have because of that increase in potassium. This leads to acidosis. The patient's going to start having dysrhythmias. And let me tell you what happens, or the symptoms that you're going to see happening. The first thing that CRNA, when she's sitting there watching that patient, and all of a sudden, she sees this quick rise in the end-tidal carbon dioxide level. That machine is going to be monitoring carbon dioxide. And we know what carbon dioxide does to our respiratory tract, right? So she can be sitting there and all of a sudden the CO2 level goes out the wazoo. I mean, it goes up so high. And then, of course, when it goes up high, the O2 is going to go down. So what we're going to start seeing is the patient's heart rate is going to go extremely high. And I'm talking 160s, 170s, 180s, 200. So that CO2 is going really, really high. We've got calcium coming out. We've got potassium going up, potassium going up. That's when we're going to see the tachycardia. We're going to see the respirations begin very, very quickly. Patients become very rigid with their muscles. Their urine starts turning Coca-Cola colored. And the late sign is patients can have a fever up to 111. This is a very dangerous side effect that happens. Yes. Huh? This is on my brain. Absolutely. Absolutely. The kidneys are working as hard as they can work, and you know what they're saying? I can't do this. All that potassium, all that calcium, and they're saying, okay, guys, I can't do this. So this is a sign of saying, I need help.
Is it possible then, if that's the case, that
They could go into kidney failure, but right now, I got to worry about them breathing and all that good stuff. Okay, but what you're putting together here is a multi-system problem. You first started out with some cardiac issues or respiratory because of that increase in CO2, right? Then as that increase in CO2, then I'm going to start seeing my heart react by tachycardia, right? And seeing some arrhythmias. Then we're going to see the kidneys saying, hello, if the lungs and the heart are in trouble, I'm in trouble too. And that's when I'm going to see the color urine, and I'm going to see that temperature go up as high as 111. And that's pretty daggum scary.
I think they minimize it because it's part of the anesthesia questionnaire as to if you've been related to anyone with it. Because I graduated college 6 years ago, and I've never, knock on wood, ever seen, and it's something like you hear, just like when someone goes in the OR, gets talked about.
Oh, yeah.
And I've never heard of it, but there's one main anesthesia med that causes it. So, we don't use it for fleas. And if you think that someone you were related to had any sort of complications or surgery, they won't use that.
Absolutely.
And there's a card, just how you have contact cards in the OR, there's an MH card, and you don't say it. Don't go in there asking Malignant Hyperthermia. It's like a taboo word. You not ever mention it. But
we don't, you know how sometimes we're like, oh God, let's talk about a cardiac arrest. No, we don't talk about a cardiac arrest because sure as the world, our patient's going to arrest.
Or this is the meeting and oh, it's a slow day.
Yeah, because never say that it's slow. Never say it. So we're not using this terminology in here, but I do want you to talk to the CRNAs when you get a couple minutes and say, how many cases have you seen? But and some of them haven't seen a lot in their career, but they know that this is scary. This is scary. The other thing is, like Samantha was saying, is in that pre-op situation when we're talking to our patient and saying, tell me how you react. Did you have any complications from anesthesia? I don't say, did you have malignant hyperthermia? No, I don't say that to them. But I can tell you that if they've ever had it and they have to have surgery again, you can bet it's going to be like flies on poo-poo in there to make sure that they don't give the medication that could cause this and that they are really, really watching that patient. But the key to the whole situation is early detection. So when that CRNA sees that just sudden rise in that end-tidal CO2, they've got a drug that they have. And remember, I've tried to teach y'all, you always prepare for the worst scenario. You always prepare for this patient to develop malignant hyperthermia. And if they do, then what do I have right there with me? I have some dantrolene, and you can bet your bottom dollar, especially with pediatric patients and with young adults, that CRNA has that drug right there readily available. Overdose, of course, we know what, as a complication of anesthesia, overdose is something that is very, very common. Those are not common, but I think are getting better. We're getting better because we're not just going in and shooting the patient up with a bunch of drugs. We're giving them an opportunity to react. They're giving them a little bit and see how they respond. So we're not seeing the overdose as much as we did see it before. And all right, so these are the complications. I'm going backwards. I'm struggling this morning. Okay, so we've talked about malignant hyperthermia, and we've talked about overdose. All right, so let me quickly go over the complications of intubation, and then I'll let you take another breath. All right. All right, so we've talked a little bit about intubation and staying away from those cords, right? So that is one of the biggest things that we, as nurse anesthetists, when they put the patient under, they are looking for their cords. But you can also see that they may break teeth. They may have swollen lips and any trauma to the vocal cords. You've got to make sure when they are intubating the patient, you will see that they have got that head really extended back like this, because what is it doing to this area?
Opening.
It's straightening it out, and I'm going to have a better view of where I need to go. When you're in the OR, I want you right behind that CRNA looking down that airway, because I don't know that you really have ever looked at an airway before. I mean, you stick your pen light into your patient's mouth and look at their teeth and look at their mucosa, but have you really looked at an airway? When you look at it, you're going to have a new respect for how important it is to maintain that airway, because it's pretty small. It's not real big. And think of the damage that can be done if we don't maintain someone's small airway. They die. You know what this? And they die. If we don't maintain it. Okay? So I want you to go in the OR. I want you to look behind that CRNA. I want you to look to see how important it is to keep that airway open. Okay? And we talked about yesterday, our patient's throat being very, very sore. Well, this is the reason why. It's because, and I want you to look at that tube. I want you to see how big it is. And I want you to see it going down your throat and see how irritating it can be, and see why your patient's complaining of a sore throat.
So I know like CRNAs can intubate the
Uh-huh.
patients, but do RNs do that or
No.
Okay.
No, we have to have special training to do that. Now, one of my other best friends, you know, I've got best friends everywhere, is a CRNA, and she had a student intubate somebody a couple years ago. So if Amy's in there and she says, come on, Aaron, let's intubate, say no. You know that Miss Walker told you that we can't do this. Yeah, she might say, come on, let's go intubate. No, we are not intubating our patients. You can look behind the CRNA and you can look at the cords and that stuff, but do not put that tube down because that is beyond your scope of practice. And I don't want you to do that and damage something you ain't got. She said, I was right there with them. I don't care. If you was right there with them, don't put my students in that situation.
All right, so let's take a break. I know this stuff is entertaining,
It is.
but patients of intubation. So you know we've been talking about general anesthesia. Okay, so there's different types of anesthesia. General anesthesia, you know, has the four issues that we're going to be, that you have to have a balanced anesthesia. So another anesthesia is local anesthesia. You're going to be seeing patients that just get local. And what I mean by local is that the medication is actually injected into an area that it works with the nerve impulses. So it deadens. Have you ever been to the dentist and they gave you shots? Local anesthesia just gets that specific area where the nerve impulses are diminished. The patient cannot feel it. The one good thing with this is they don't lose consciousness. So if they don't lose consciousness with local anesthesia, you know that the airway and the gag reflex is not going to be bothered with this, is it? Now, does that mean that the patient can't have a reaction to it? Yes, they can have a reaction to it, but generally, when you give a local anesthesia, then it's just a confined area and the patient is not going to be in jeopardy with that airway, okay? Unless they have a reaction to it.
Is that like what they would do for like an INT, like a small INT, they put like this?
Yeah, you could, but see, the other thing with the local is that you may not just get one shot. If you had, and that you see that with a regional a lot, and we'll talk just a little bit about that more in depth with regional. But yeah, you can use local when you have a big area and you will actually inject all around the area. Now, when moms have babies, they will actually, you may have an epidural, and we'll talk about epidural in a minute, but you may also have a local anesthetic for them to cut the episiotomy. Okay, so they may, with labor, because y'all are getting ready to go into labor and delivery, so you may have a patient who's had two types of anesthesia. Usually lidocaine is what you see. Bupivacaine, there's all kinds of, any kind of cane drugs is usually your local anesthesia. Okay, but I want you to realize that it is anesthesia. Okay, it is a type of anesthesia, but my patient's not going to be at risk for developing an airway problem unless they have a reaction to it. My gag reflex is still intact. There is also a type of a local anesthesia is topical. And topical means that it's a cream or a spray, and you can rub it on the area. One of the most common things that you see with the topical is called EMLA, E-M-L-A. And they use that with patients, our pediatric patients, when they need IVs. And it's a cream, and you just put the cream, and you put like an oxide over it. The bad thing is it has to stay for about an hour for it to get the numbness that it needs, because that's basically what we're doing with the local anesthesia is we are numbing an area that we're going to have to do something to for that patient.
When you go to the dentist, the stuff that they rub on your gums, is that considered topical? That numbs it prior
Yes,
to the
that is topical. Absolutely. Anything that we rub on that's going to give that numbing sensation is going to be a type of topical anesthesia. Yeah. Is, spray ointment used. Sometimes we use it if we have a difficult, or the CRNAs have a difficult intubation, but that's not going to be something you're going to use it for. And like I was saying, I've got, your book says 20 to 30 minutes with IMLA. Actually, it's telling you to keep it on there for an hour before. So, not that you're going to focus on the 20 to 30 minutes or the hour. Know that topical is an ointment or spray that is used to numb an area, and you will just have to follow the instructions. If you give that medication, IMLA, if it says to keep it on for 1 hour, you got to keep it on for 1 hour before it gets the adequate need or required. Required effect of the medication. But it is a medication. You cannot put anything on a patient without giving it to us first to check. Okay. This is when we think about anesthesia. We think about, we are not able as nurses to administer. We can't administer a topical anesthetic. We as nurses can. We can't do general. We can't intubate, but we can do topical. Okay? We can also do lidocaine. Local. I don't know what the policy is at Rowan, and some of you may be able to assist me with that. But I know at when I worked at Lake Norman, and I think Northeast has that, is before a patient gets an IV, they are injecting them with lidocaine or a local anesthetic to numb the area before they start the IV. Now, was that a policy? Okay. Okay, so that was like, because she may be a difficult stick, she may not like the pain, that kind of stuff. So you as a nurse can actually administer. Now, personally with me, I don't like to give lidocaine before because I think the vessels go away. It's like you can't see them as good. But if it's going to help my patient, I'll just have to go with my feel, starting IV, as opposed to the pain. I'll have to do that.
I think lidocaine hurts more.
I think it does too.
Stick.
It does. It's like, and I'm sticking my patient twice. When I can just stick them one time and get it in the vein and go.
I know at our job, especially for males, we do lidocaine before passing with some of our males.
You stick the penis?
It's a push.
Jail?
Wow, dang.
Just stick it in. Just stick it in. All right, so you can see the examples of the local anesthesia that we can actually give. We can actually give that. So it's vital, though, that you check to make sure that the patient doesn't have any allergies. Because you will be surprised of how many people have lidocaine allergies. So make sure that you check to see if there have any allergies there. All right, so that was local. So now let's move over to regional. There is we've had general, we've had local, and now we're going to regional. So regional is a bigger, local, it makes sense. Well, let's go to general, everything's suppressed, right? Local, we're just going to one little confined area. Regional, it's a bigger area that it's going to affect, okay? So if you think of it that way, it is a type of local, but for some reason, some people may choose, like me, to have a procedure done regional as opposed to general. I had my hysterectomy with an epidural. Yeah. Had a little bit of Versed and had my hysterectomy because I was not going to sleep because I did not want to vomit everywhere. So they did not really want to do it, but they ended up doing it because I pitched a fit. But anyway,
So this is a regional area, but the biggest thing is that my patient can maintain their own airway when I have a regional anesthesia going on. So it is a form of anesthesia, but it's a regional. You will also see patients who have had total knees or total hips or hysterectomies have a regional anesthetic as well as general. So they go to the surgery, they're under general anesthesia, but for post-op pain control, they have an epidural. Okay, so they may have two types of anesthesia. We see that a lot, especially if someone has like major abdominal, like I'm thinking about your patient that you went to see just last week. I would hope that they would have had an epidural in him, did they?
Yeah.
Yeah, because that was he was going to be in major trouble.
Oh yeah.
With his
Because he
pain
had an
control.
abdominal incision, and then his whole bottom was cut out and sewn shut.
So that's a pretty invasive procedure. So he had general and regional anesthesia.
I think it was fentanyl in the epidural.
Yeah, fentanyl's amazing. That's what we give for patients who have babies.
He
Give
had
fentanyl.
prior cocaine abuse, and so they think that was leading to him needing so much, and it wasn't controlling his pain.
So, but that's our responsibility to make sure that my patient is under control with his pain. And if whatever we're doing for him is not working, then we're gonna have to change the man and get something going for him. So, yeah, I've heard about that. Intense. Yes.
Can nurses give regional anesthesia since
No.
it's a type of
No, it's an epidural, and we'll talk about the different kinds in just a minute. No, this is beyond our scope of practice. Can we administer through the meds? Yes. We can watch, we can get, and let me explain that just a minute. Okay. All right, but remember this maintains their own gag reflex. So one of the types of regional is field block. This is actually a series of injections, not like an epidural. This is like a series. So in other words, if I have a patient who can't go under general anesthesia, I can give them a large, like who was our COPDer? Your little COPDer. If there would have been any way we could do a large area for his surgery to give him injections all around that site, that would have been the ideal situation when a patient who's not going to be good for general anesthesia. Okay, so they can actually use a regional anesthesia for patients if it's a large amount of surgery. For instance, I had skin cancer right here, and they used, because I wouldn't go to sleep, and so I was awake trying to help the surgeon, but he wouldn't let me. But they did regional all around here. And so that was a pretty big area that they had to numb. So some people I don't like to go to sleep, y'all. Don't make me go to sleep. I mean, I like to sleep, but I don't want to go under a general anesthesia. So it's like they can use that to take off I had a big old mole there, had a big crater in my, that's another story. I got all kinds of stories. But anyway, we use these, your book says hernia repairs. I have never, ever seen anybody have a hernia repair with a field block. Just had never seen it. But that's what your book said. Nerve block. Now this actually goes in to the nerves. Okay, so it's a group of nerves. It interrupts the sensation, and it's used more, like I said, for pain relief. Like epidural. One of the biggest that I wanted to list, the cane drugs. These are the most common medication that you're going to see is the lidocaine, xylocaine, marcaine, and bupivacaine. That is the most common cane drugs that you're going to use. You can use for local and topical and for regional. Okay, so you can use those. But you've got to make sure that it's taking effect. It doesn't happen instantaneously. You've got to wait and make sure. So you will see whoever administered the medication, you'll see them use a sharp object and like poke the area to make sure that the patient can't feel that. Okay, they may even pinch it a little bit, but the ideal is to make sure that when I touch the area that they're going to be working on, that the surgeon's going to be working on, or whoever's going to be working on, I got to make sure that they don't feel it. And if they still feel it, then I either have to wait a little bit of time or I have to inject more. Okay? All right, spinal. Now, there is a difference from a spinal. This is still regional because it's a bigger region. Our regions are getting bigger. Y'all need to shut that door, are they loud? Are they louder than me? Seniors follow us. Okay, so our region is getting larger. Spinal is also called interthecal. Remember, this actually goes in to the subarachnoid space. So, you know your anatomy and physiology. If it goes in, what do you immediately think of if it's going into the spine? Paralysis. Okay, because it's actually going into the spine. And if I go into the spine, there is always that risk of paralysis. So, this is one that we have to make sure the anesthesiologist is going into the right space with this. Because if he goes too far, then there is a major, major risk. The risk is not there so much with epidural, and I'll explain that in just a couple minutes. But you may see patients have this when they cannot have general anesthesia, like hard-headedness me. Cannot have general anesthesia. We can use these when they have low abdominal surgeries, vaginal surgeries. We can use this as opposed to general anesthesia. When moms have C-sections, we sometimes use spinals and sometimes use epidurals. The bad thing about spinals is that the patient has to stay flat 6 hours after the surgery. So this would probably not be a good choice for a mom who just had a baby, okay, for a C-section. Epidural would be better. But with spinals, we've got to make sure that they lay flat, because what can happen is the medication can go up the spine. If it goes up, what do you think is going to happen? It's going to start paralyzing or suppressing this area, and then my patient is not going to breathe. Okay? So you have got to make sure that you keep those, and I mean flat. Flat. The other thing that you see a lot with spinals and epidurals is severe headaches with patients, and they're called spinal headaches. And what might have to be done after, if they continue to have these headaches, is they may have to do, and I don't think I wrote it down here, they may have to have a blood patch. And what that is they actually take blood out of the patient, about 10 to 12 cc's of blood. So that's a pretty big syringe full of blood. They go back into the area, into their spine, and they inject the blood. And so the blood, because it's got a track of where we went into, right? Let me see if I can draw this. I'm not a good drawer, but let me see if I can draw this. Somebody don't take that poster. All right, so this is the track that we did, and here's our spine, right? Okay, so here's our little spine. And here is the track that I put in the spinal or the epidural, right? My patient's got severe headaches. They're dizzy. Lights bother them. You cannot, it has to be dim. I'm talking, if anybody's ever had a migraine, this is like 20 times worse than having a migraine. Okay, it is awful. Patients can't hardly open their eyes. It's awful. So what they do is they actually take the blood, 10 cc's, and they inject it into this tract and fill that up with blood. And when they fill that up, it seals it, and the headaches almost instantaneously go away. It's crazy. Crazy, crazy, crazy. But the moral of the story is listen to your patients after they've had spinals or epidurals. If they say to you, my head hurts, that is a significant. Don't make them wait and give them some ibuprofen because you got a headache, because this headache is not going to get any better until they get a blood patch. Okay? It's very, very important. All right, so epidural. Now, the difference in a spinal and an epidural is the spinal goes into the spinal column, straight into the subarachnoid space. Epidural does not. Epidural goes into the epidural space. And when you have an epidural, the nerve endings stop way down here. Here is my spine, and here's all the nerve endings. The epidural space is below where the nerve endings stop. So paralysis is not going to be something we worry about unless they get in the wrong space. Yeah, can y'all tell what my little drama means? Can y'all figure out that's the spine, and these are nerve endings, and this is the space below the nerve endings. You got it? Yeah. Can y'all figure out what I mean? This is the spine, and that's your nerve endings.
I'm trying to see your vision.
The moral of the story is, with the epidural space, if you put it in the correct place, then the patient cannot have paralysis because the nerve endings stop above where they're going to inject. Does that make sense? Are y'all with me? If the drawings or not? Y'all are with me? Okay, so, same thing that can happen with this is it going up. We do not have to lay our patient flat for 6 hours with the epidural, but the medication can go up, so the patient may have some respiratory issues as well. Okay? The biggest thing that happens with a patient or taking care of them with an epidural is they can't know when they need to pee, because they're paralyzed or numb from here to here. That is an ideal epidural. Who's had a baby that was numb to their toes?
I attempted to walk after I had my baby, and they're like, stay in the bed, and I was like, I can do it. Yeah.
Okay, for some reason, you don't need to be numb to your toes.
Yeah.
Because the idea is here to here.
So why did it?
There again, everybody is different. And how you respond to the medication. Do you want my honest opinion? Or do you want my professional opinion? Okay, my honest opinion is that the anesthesiologist is coming to put the epidural in, and you're having a baby. You're in a lot of pain. So he wants to get rid of your pain, so he shoots you with a lot of medication that you probably don't need.
I mean, my pain went away real quick.
Yeah, it's quick.
Because you're in a lot of pain, and he wants to get rid of it. So he's giving you probably more medication than you need. And that's why you're going numb to your toes as opposed to stopping right here. Yes.
I think that's what they tried to do to me. They found out that was a very bad plan because my blood pressure shot through the roof.
Through the roof or down?
Well, apparently it went up and then went poof.
Right. Very, very common thing that happens for patients who have epidurals. So, as a nurse, what would you want to happen, or an intervention that you would want to do prior to your patient getting an epidural?
Fluids.
No, not epinephrine.
Fluids.
Huh?
Make sure you don't give them blood pressure meds.
Okay.
Fluids.
Fluids. Fluids. You are going to see them bolus that patient that gets an epidural at least 500 cc's of fluids prior to getting the epidural. If that doesn't happen, then you better watch your patient because they're going to bottom out.
Well, the anesthesiologist backed it off. Like, he was right there, like, injecting it. And he was like,
Do you remember when y'all were getting your epidurals? I know you were in a lot of pain. Did they give you fluids before?
Yes.
Fluids before. Did you bottom out your blood pressure? Four. Got 4 kids. Bless your soul. I thank God I stopped after them. But, yes.
So if it only works, it only numbs you from like your belly button up, it would be not enough.
What, baby?
Like you get, yeah, but that's what it's ideally supposed
Right.
to. But it only does from like your belly button up. It would be not enough.
Not enough.
And then I'm on the same room said hers was like one leg, but not the other one. Or
Another thing that's very important. You brought this up. If she's saying that her mom was only numb on one side, and you know why? Because they had her positioned on that one side. So all the medication went down this side. So what do you want to do? You want to make sure that your patient is, and I don't like to put pregnant women on their back, but I put them on their back because I want to make sure that it goes down. I don't want it all the way down the leg. I want their bottoms to be numb. Okay, but if it's just on this leg, then you as a nurse have to change that patient's position because the medication is not going where it needs to go. Okay, so back to epidurals. Just a minute. Epidurals not going to have paralysis with it because of where it goes. Okay, you know that it's going to be a side effect is hypotension, meaning decreased blood pressure. And I'm talking patients drop their blood pressure 80/40. So a nursing intervention would be give that patient a bolus of at least 500. But tell me what I would assess before I pop them with 500. Huh? Electrolytes, absolutely. And to see if they are their intake and output, to see if they are dehydrated, because that 500 may not be enough. Okay, we might need to shoot them with about 1,000. But we know that that's a side effect of dropping that pressure, so I'm going to bolus them. And I also need to know that they're numb and they don't know they need to pee. So what you better do for a patient who has an epidural is you better keep up with that to see if their bladder is distended. Because they can't tell you, I have to pee. Yeah. Well, if they're in the middle of giving birth, I can do an in and out cath on them and empty the bladder. But prior to, and what happens with labor and delivery patients is their babies are not coming down the canal. And it's hours after hours, and they're sitting there and they're not, their bladder's full. So, yeah, cath them. But I don't want to get them to the point where they're cathered. Because that's an invasive procedure, right? I don't want to do anything I don't have to inside their body. So then, as a labor and delivery nurse, every hour I'm making sure they can get up and go pee-pee or, something. I got to get them. I'm putting them on the bedpan because they've had an epidural and they can't get up and walk. I'm doing something to make sure I'm pressing on their belly. I'm checking for bladder distension.
Can they still go to the bathroom since they can't feel?
If they're numb to their toes, absolutely not. So you got to assess to see how numb is my patient. If my patient says, I'm numb to right here, I don't take them all the way to the potty. I get a bedside potty, pull them up, sit them down, let them pee, and get back. Because patients don't like to pee on the bedside. I mean,
But once they gave me the epidural, they said that's it. You're not getting back
That's what
up.
Yeah,
They-
you gotta go before you get out.
yeah, they did in and out for me.
yeah, we don't want to do. We just got to keep up with. If you're in labor and that bladder's full, you're not gonna get that baby out. You're not gonna get it out. He's gonna stay in there forever. So get that bladder out of the way and let's get this show on the road. Because I'm always ready for a birthday party.
So for like this unit, is it our responsibility to know the CRNA's job, or more? You understand what I'm saying? It's just information.
Right, it's information. You know what they do. You don't have to do what they do, but you need to know what they do.
So we do need to know what their job is.
Yes. Yes. All right. So epidurals. We definitely are going to check the bladder distension. We're going to bolus them before. And no, we are not getting them up until they have full movement of their legs. Okay? Because as soon as they have the baby, they don't need the epidural anymore. The epidural comes out. The medicine's cut off, epidural comes out, and that medicine will start reabsorbing. Okay? Do not get them up. I always make them tell me, how does your legs feel? But I still take a sharp object, and I may not pinch them, but pinch them to see where they're feeling it, because I'm putting their safety jeopardy if I get them up and they can't walk. All right, when we're looking at problems with anesthesia, whether it's local, regional, general, if my patient starts showing me these signs and symptoms, restlessness, what's that telling you? Maybe hypoxic, excitement, might have had too much medication, incoherent speech. These are all, the blood pressure might be going crazy, headache, reaction from spinal or epidural, blurred vision. Epidural, you may be your blood pressure bottoming out or being high. Metallic taste in your mouth, that is a side effect of an epidural in the spinal. Nausea, vomiting, tremors, seizures, all these things happening are all signs and symptoms of adverse effects of anesthesia. And what are you going to do if your patient starts?
Call Miss Walker.
No. Gail, Miss Walker. While you're in school, you can say, Miss Walker. But after it, this is what we're going to do. First, we are going to establish that airway. And then you're going to give O2. Then you're going to call the surgeon. At that point, if you know what's going on, i.e., if you just gave them morphine, and they're dropping the respiration, or their respirations are low, and you know you've got an antidote, so you can give it, right?
Yeah.
Okay, so there's lots of things that you can do, but you're not. I'm stressing to you that every anesthesia medication can possibly cause a side effect of messing up their airway. You got to learn how to react. All right, so that was just sort of like a.
So does one of these side effects?
Absolutely, any of them. Now, the reason why I put that up there is because I want you to realize that it's all about assessment skills. Your patient, you know that no, you didn't administer all those general anesthetic medications, but you're getting ready to take care of somebody who just had those. And you know that all of those are side effects of that medicine that they just had. So you've got to be prepared that this might get a bad situation, and you better make sure you monitor, or you better get that airway clear. Okay, so that's the moral of that story. Okay. All right, so moderate sedation. These are just IV medications that decreases our patient's ability to have, or decreases their level of consciousness. These are the ones that you'll see a lot with endoscopies or colonoscopies. The biggest things with moderate sedation is that they can verbalize to you and they can maintain their own airway and they can respond to your verbal commands. And those are Versed, which y'all are going to see all the time. All the time. Backwards. I am going backwards. The biggest thing that you may see with moderate sedation is the patient is going to go home after they have had this sedation. They're generally going to go home. So you still got to make sure that they have, you've got to monitor all those issues, O2 sats, vital signs. Remember when we talked about pre-op, how the patient has to meet certain criteria before they can go home. The same thing with moderate sedation, especially if they've had come into a procedure, they've had moderate sedation, they've got to meet certain criteria before they go home. All right, so this is our assessment part of when we're in the intraoperative. We're still in the intraop. Means I'm still in the OR. Identify your patient. Validate the consent form. Ask them when they bring the patient into the OR, they ask them what type of procedure are you having. They don't say, are you here to have a hysterectomy today? We make the patient verbalize to me exactly what they're having done. They're also going to tell me which surgeon's going to be doing it to make sure that they understand what we're doing. We're going to validate which side is being on. Is it just like Kelly was telling us? They said, tell me which eye you're going to be operating on, so they know which one. Check about allergies. Make sure that autologous blood's on site. Make sure that they've got everything off of them they should have off of. Medical records are reviewed again. Remember, DNR is suspended. So there's many checks that happen while you're in the intraoperative phase. So let's revamp on intra-op. What kind of questions do you have about intra-op? I think I have talked about positioning. I think I've talked about that. All right, so let's recap intra-op. Look through your notes or look at it and see what we need to ask me questions about. Y'all got it? So intra-op, we know there's a scrub nurse. What's her responsibilities?
Sterility,
She can assess, she can count, she's going to stay sterile, not scrub. That's circulating. Circulating nurse, she said over the whole room. Circulating nurse is over the whole room. Scrub nurse is counting. She stays sterile. She assists the physician.
Assessment of patient.
Huh?
Assessment of patient.
She can assess patient. Surgical techs can't. Okay? Because they're the ones that's right there with the surgeon and they can say, okay, there's a bleeder. And the surgeon doesn't see it. Okay? Okay, so what about the circulating nurse? She's the ringleader. She's responsible to make sure everything's sterile, make sure everything's in order. If the physician needs something, she runs out to get it. Who's going in and out? Documentation. Skin prep. Positioning. keeps in contact with the family, documents, absolutely.
Keeps up with the biopsy, like if there's something that was taken out, she takes it to where it needs to go.
Cool. This is where I want y'all to share things that y'all see other. She was saying that when the biopsy was taken from the patient, she's the one that makes sure that it's labeled correctly and that it gets to the appropriate place.
Leave it out and tell my mom that this is what is taken out.
Good. Good. She charges.
Everything's already prepared for the surgery.
Mhm.
And if the surgeon needs something for the surgery, she just needs to make sure she charges it and works faster.
Right. So in other words, when, let's say I'm going in for a hysterectomy, the tray that's already in there is already set up with everything that I need or the surgeon needs for that surgery. But if we contaminate something or if we need an extra of something, circulate nurse goes out to get it, and then she has to charge the patient, which is awful. I hate to hear that word.
Even if it's our fault, we contaminated it.
Yeah. Timeout. We didn't talk a lot about timeout, did we? Is that not in your notes?
It doesn't say kind of specifically, but it explains it. I mean, we went over it, but you didn't like break it down as what it is. But you did like talk about it.
Why did I take it out of my notes? Okay, timeout. I'm glad somebody said that. Because what happens in the OR, once they get the patient in the room, position, everything's safe, the patient's getting ready to go to sleep, before the procedure stops, the surgeon will say time out. And when he says time out, everybody shuts up. That's basically what it is. You're quiet. And it goes through one last check of everything, this patient's name, their age, what they're having done. You have to identify everybody. If you were in that room, they're going to go around and say, identify your name. So they'll have everybody that's in there of who is in there. One last check. And everybody has to agree. If one person doesn't agree, then they start all over. And they figure out what they're not agreeing on. Okay? Like if it's the right leg and it's supposed to be the left leg. Something to that matter. So the timeout, there is a big old poster at Northeast. And some of the surgeons will walk over to that poster and they'll go through the questions of everything that's supposed to be addressed during that timeout. Some of them have done it so much that they know what's on it and they don't have to, they can just say it. But I like that timeout because I think it's just, I don't think we can do enough checks. I honestly just don't think that we can. The OR to me scares me because so much can go wrong and we can leave stuff in people. So we've got to put things in effect. Not that it scares me as a nurse. I don't get scared as a nurse. But it scares me at things that could go wrong. And I love to see the fact that they're doing stuff that they saw. The counting was a big problem. So we've got to look at ways that we can make sure that this count is done correctly. The timeout has not been around that long. So it's just one more check to see, okay, we got to make sure that we've got the right patient, the right procedures. Because I would hate to go in and have some surgery and come out with no leg. You know, I'm going to have operating on my bladder, but I come out and I don't have a leg. You know, so it's like that one more chance to check to see, are we doing the right thing? So that's our circulating nurse. CRNA, pretty big job, huh? Biggest responsibility is maintaining that airway and giving the medication that's needed to meet what?
Patient's needs.
Meets the patient's needs, but general anesthesia hits 4 things. Amnesia, pain, muscle relaxation, and hypnosis. So there is a combination of medications that are given, and each one of them have different jobs, right? But we got to get them all together to meet the needs of the patient and making sure that they're asleep. What else? Y'all hadn't had a chance to digest it yet, have you? Haven't had a chance to digest it. I don't want to get into post-op yet, because I got one more hour in the morning, 9:40 to 10:40, and then Miss Beaver will come in after. So we'll do post-op tomorrow. Monday. Monday is the test. All right, so what other questions y'all have? Y'all have a plan? Would you like for me to go check to see if she would like to do the review since I'm done?